Now all three presentations are open for discussion. Who wants to start? As usual, it takes some time until people collect, but there's the first one. Do we have a micro or just in the... Yeah. Okay. Please.
Professor Augustin and your fellow speakers, I want to congratulate you on your approach. There is absolutely no question that if we can push the inflammatory phase more into the proliferative phase, that we speed up wound healing. And we continue to hear this gibberish and nonsense from the various committees from, peddling the biofilm story. It's so much more refreshing to see that we're actually using the pathophysiology of basic wound management of the wound. I have one question, and it is purely to try and explain how pushing it from the inflammatory phase into the proliferative phase might or might not work. And I too agree with you from my long practice in the wound clinics in Australia, where I come from, that the key element of the inflammatory phase is the macrophage. And then we have the key element in the proliferative phase, which is the fibroblast. And if we can enhance fibroblast proliferation, of course we're going to move that along, regardless of what the heretics peddling this nonsense about biofilms is. And do you think there is any connection between a macrophage and a fibroblast? For example, since the advent of molecular biology only in the last 5 years, we're now getting the picture of the wound healing story ever so much more correctly, if I might use that word. And do you think that there might be a situation where the macrophage actually becomes like a chrysalis, the fibroblast?
Ron, do you want to comment on this? Otherwise, I take the next answer. Is it something which you want to...
Thank you. And thank you for raising the issue of using common sense like pathophysiology and biology. You couldn't make my day more than this. Thank you, sir. But I'm not sure. I think cells can differentiate. And indeed, in the last 5 years, we've seen so much of our standard thinking proven wrong by these cells. I think it's possible that I think we know already that macrophages are very much in the center of the healing process, and it gives orders to cells, it takes orders from other substances. Whether or not it could differentiate into a completely different cell type, that I do not know.
The reason I bring up this very topic is that the proponents of things such as biofilms and all the other comorbidities, if you like, that stall a wound, are advocating debridement, surgical debridement, and even though when they surgically debride it and find that there's biofilms still living there, or still there, they're then advocating more surgical debridement. When do they accept that they're wrong? Yeah. So the situation here is that if we can get the macrophage, or identify that it's the macrophage converting into the fibroblast, what I'm saying is that if you then go and debride that, you're going to stall that wound by taking out a very valid natural step, which they just don't seem to understand. Yeah. With all the eminent people on their committees and all the rest of it, they're ignoring the basic facts about what we know about pathophysiology of wound healing. And I think it's so refreshing to hear you people using this very basic element and saying this is where we should be looking for stalled wounds and the explanation to stalled wounds and progressing them from there.
Thank you. Thank you.
I think thank you from my side that there's a narrow gap between damaging and supporting wound healing by debridement, for example, and we should make use of it when indicated. But I agree with you that we also need to be aware that it's the cellular components and their interaction which really drives the process in the one or other direction. And I don't know if it's a must that there's a transformation from macrophages to fibroblasts, but more of an interaction. We know that both macrophages and fibroblasts are pluripotent in many ways, not just by producing and releasing wound healing factors and which interact, but also by changing their functionality, like myofibroblasts in the sense of fibroblasts. And so this diversity obviously is needed for proper wound healing and for stretching out from an early into a later phase of wound healing. I think this was your point. And obviously, it's not just one single factor which we should increase, but it's an overall one. And now coming back to Woulgan, to the beta-glucans, obviously they have the capacity to improving the phagocytosis and functionality of macrophages and their activation status in the wound in a very specific way. It's just a certain type of glucans, and maybe others can explain this better, but which have the capacity to inducing both the differentiation and the functionality of macrophages. And obviously these cells are key in the process. Are there more questions or comments? Otherwise, I would like to ask Brenna, now having your clinical experience with Woulgan, can you precisely describe patients where you would apply this component first? I mean, when we get something new, we started at the most desperate patients, those where everything else has not been effective, and so it's a little unfair to start like this. But over time, you may have emerged a good sense of where you would use the product. What is your notion on that?
Yeah, we had a discussion earlier actually about whenever you see something like this, you tend to use it on the worst case scenario, and I think we need to be thinking, and again the idea that we wait for 4 weeks. Should we wait for 4 weeks for a wound before we say it's actually stalled? And I think that to put timescales to wound healing is quite challenging. And I think that probably earlier intervention, we might see better outcomes, rather than waiting for it to be stalled for a number of weeks.
Mm-hmm. Not just for economic reasons, but also for physiological ones. I agree. Yeah. Another question, Brenda. Do you have you seen any side effects, any intolerance of Woulgan in the patients you observed?
No, the majority felt more comfortable. I think there was one report of pain, but whether it was associated with that, I think there was some confusion at first with possible worries about infection, and I think that again is understanding what it's like when you first treat him with the Woulgan. But other than that, not really. And on the ones where there was no significant change, I think that was seen fairly early on.
Mm-hmm.
So, yeah.
Actually, we had the same experience, not in a controlled trial, but in roughly 20 patients that we treated. Not all showed improvement, which is normal in such hard-to-heal wounds, but several showed marked improvements, and also especially a good cleaning effect and a resolution of sludge and sometimes even necrosis. So obviously also the autolytic process is induced. And beside of this, maybe phagocytosis also in clinical condition, not just in the lab. Yes, Bibi, and then in the back.
A practical question, how often do you have to apply it? Just once a day, or can you
Usually twice weekly, standard, but there were some in the evaluation that were weekly, sort of weekly dressing changes. There was one that was excluded that was used every day, which is not really advocated. So, yeah.
Mm-hmm. Thank you. Next question, please.
Well, actually, it's not especially a question. I'm Jacinta Wilming from the Netherlands. I'm an equine veterinarian, so not a point of view. I'm working for 15 years in treating wounds in horses, and what we see is that the problems in horses are mainly caused by the fact that the acute inflammatory response is not sufficient. So the way treatment and healing can be improved a lot is by stimulating the acute inflammatory response. In fact, a little bit like the beta-glucan. And what I use a lot is, for example, the alginates that also are said to stimulate the macrophages. You see enormous difference in healing. If you go in the beginning, if you start treating the horses with relatively acute wounds, with the alternates, you see new formation. So you act with the physiology or the pathophysiology, and then you stimulate the formation, the inflammation, and formation of healthy granulation tissue. And after that, you see a better wound contraction, which is desired. But what we see very clearly, I always use the stimulating thing until the wound is completely filled with healthy granulation tissue. And then you have to stop, because otherwise you overstimulate the processes and the inflammatory response, and you get, indirectly, you will inhibit healing. So because we were talking about when do you have to use, how often do you have to use it, what I do in another type of species of animals, I use it in the beginning, I use it until it's necessary, and of course during every bandage change, when bandage changes are necessary. So in fact it's a similar approach in another species, but with another product, because I used the alginase, but it might be very interesting for equine wound management too. So that's from another perspective.
Interesting.
Thank you for this comment. It's enriching to compare this, and there may be some similarities, but also differences, because
There are
in chronic
many-
wounds we have a chronicity with all problems
Yes.
associated, as you know.
But there are many similarities between the chronic human leg wounds and chronic equine wounds.
Okay,
And by the way,
chronic.
tomorrow we have a symposium, veterinary symposium, and that is one of the things that's coming along. But nevertheless, in fact, equine wounds are a very good model for non-healing human leg ulcers. So that's
Okay.
true.
Thank you for that. I don't see any further comments, and we want to be perfectly in time, which we are now. So I thank you for your attention. I thank the speakers for the excellent contributions. I thank Woulgan for hosting us, and I wish you a nice afternoon. Thank you.
Thank you.